Hi class, this is Professor Alabozic. I just wanted to add in a separate voiceover from the PowerPoint on the oncology case study because I thought it would be a good thing for us to go over. We didn't get a chance to do it in class. So I'm just going to go to the next slide and we're going to go over the case study question. So the patient, Mr. B, is a 64-year-old male with a history of chronic lymphocytic leukemia, CLL, and with a white blood cell count of 64,000. He was treated with IV chemo, Trienda, on days 1 and 2. Later in the day, after the second dose, the patient called the prescriber and was complaining of left flank pain and shortness of breath. He was instructed to return to the infusion room, where a review of systems revealed additional complaints of reduced urine output. So his urine output is down. He's having dysuria and anorexia, so he has no appetite. He had no cardiac complaints. His blood test revealed a blood urea BUN level of 50, a creatinine level of 4.9, a uric acid level of 19. His serum electrolytes were abnormal as well, with a potassium of 5.4, phosphate at 8.9, and a calcium level of 6.9. His EKG revealed tall T waves and a heart rate of 88 beats per minute. His home medication list was reviewed by the nurse and included allopurinol at 300 milligrams daily. So our first question in the case study, now that you know an overview of Mr. B's presentation post-IV chemotherapy, what are some red flags? So hopefully you're thinking that this disease process started shortly after chemo. So that should just kind of be, you should be thinking in your head, okay, why did this just start after chemotherapy? He's having left flank pain, that's a concern. He's having shortness of breath. A big one is he's having decreased urine output with dysuria, and he has a loss of appetite and nauseous. He has an increased BUN and creatinine level, an increased uric acid level, hyperkalemia, hyperphosphatemia, and hypocalcemia. So his electrolytes are all off, so that would be a real danger to me as a nurse. He's starting to have some EKG changes. As I noted, he's having some tall T waves, which can lead to dysrhythmias. So possibly because all of his electrolytes are off, we may have dysrhythmia issues. Heart rate is okay right now, 88 beats per minute. The next question is, what would you diagnose Mr. B with? Now, just taking a look at all of his signs and symptoms, especially the off electrolyte levels, I would hope that you would be thinking in your head possibly a tumor lysis syndrome. So tumor lysis syndrome, it's a potentially life-threatening metabolic disorder, and it's characterized by elevated uric acid levels, elevated potassium and phosphorus levels, and decreased calcium levels. So he's kind of like a picture-perfect patient of what would happen post-chemo. It's very typical for patients to develop tumor lysis syndrome, especially if they do have leukemia. So what are the signs and symptoms of the syndrome? So typically patients may experience a variety of signs and symptoms related to tumor lysis syndrome, but the body systems primarily affected include the heart, kidneys, and the GI and neuromuscular systems. Cardiac dysrhythmias can be common, especially because of the high potassium levels. That's very fatal. Acute kidney injury and hematuria may be present. The patients can also develop neuromuscular symptoms, especially like tetany, as well as GI symptoms such as nausea and vomiting. And the patient is experiencing anorexia in this case study. Tumor lysis syndrome is also very potentially life-threatening. It's a metabolic disorder. Again, it's characterized by elevated uric acid levels, elevated potassium and phosphorus, and decreased calcium. It's most often seen 12 to 72 hours after administration of chemotherapy. So this patient's right on target for that. Tumor lysis syndrome occasionally may be present prior to the start of therapy, but it's mainly after chemotherapy. And leukemia is one of the most common cancers that tumor lysis syndrome can happen. It's really the pathophysiology of tumor lysis syndrome is really a result of large numbers of malignant cells that die due to chemotherapy going on. So when chemotherapy starts, it's going to start killing those cancer cells, and it's going to start killing those malignant cells. So they're going to start dying. But when they die, they release their intracellular components, such as potassium, phosphorus, nucleic acids, right into the bloodstream. So that's what causes the elevated electrolytes to happen. And it goes right into the bloodstream. Because the kidneys cannot excrete the excess uric acid, it begins to precipitate in the kidneys, which results in acute kidney injury, which is why he's having the flank pain, he's having the decreased urine output and dysuria. The kidneys also try to eliminate the excess potassium in the blood, and that results in a fluid volume deficit. So there'll be a reduced intravascular volume, which in turn, again, leads to acute kidney injury. Also, something very important is that the excess phosphorus binds with calcium, which is why the calcium levels decrease in tumor lysis syndrome. So what medication would we want to hold and why? The allopurinol is a big one. It's important to hold the allopurinol because many patients get put on a medication to treat tumor lysis syndrome, which is called rasburicase. The spelling for that is RASBURICASE. So it actually helps convert uric acid to allotonin, which is very soluble, and it helps the kidneys eliminate high levels of uric acid. So we need to place the allopurinol on hold because it may interfere with this medication, the rasburicase activity. As allopurinol does reduce uric acid formation, and the rasburicase acts on uric acid to convert it to allotonin, so it's easier to excrete through the kidneys. So we do need to put that allopurinol on hold. So what is the treatment? What's the nursing management? As nurses, how do we want to treat Mr. B? So first of all, if they do order the rasburicase medication, we'd want to get that going as quick as we could. Allopurinol, making sure that medication is on hold if a patient happens to be on allopurinol. We want to push fluids, normal saline. That's going to help fix our acute kidney injury. It's going to get those kidneys moving. So we want a lot of fluids. We want to promote that diuresis. Okay. Taking strict INOs and taking outputs, and also daily weights. So we want to keep a close eye on the fluid intake, making sure that they're properly hydrating as well as diuresing at the same time. We want to avoid nephrotoxic agents such as NSAIDs, so anything harmful to the kidneys we really want to stay away from. Manage electrolyte imbalances. We may have to modify the diet for the patient. For the meantime, keep them on a low potassium diet or a low phosphorus diet. So limit any intake that will heighten those electrolyte levels even more. Make sure, the patient's safe. So because the calcium level is low, the patient may be more at risk for seizures. So we may want to provide some seizure care, seizure activity, maybe some seizure pads, just to be prepared, just in case that will happen. And also monitor for arrhythmias. So the patient should be on a telemonitor to make sure that there are no dysrhythmias, especially in the time where electrolyte levels are very off. So really the main thing is fixing the acute kidney injury, because that will increase urine output, and increasing urine output means that our electrolyte levels will normalize, and that is our goal of treatment. So I hope you did well on this. I hope you were pretty close to my answers. I'm sorry we couldn't go over this in class. But if you have any further questions on this case study, please email me. And thank you for listening in.